a 56 years lady, homemaker by profession, presented to us with chief complaints of pain, abdomen for last 5 months and abdominal lump for last 5 months. Patient was apparently well 5 months ago when she developed acute onset pain abdomen, uh, uh, which was adulating in character. The pain is non-radiating and has no aggravating or relieving factors. There is also a history of abdominal lump for last 5 months in the right upper region, which is gradually progressive in size. There is no history of jaundice, vomiting, there is no history of melena. There is history of anorexia and weight loss present. Patient has no known comorbidities. There is no past history of tuberculosis or surgery, and she is a non-smoker and non-alcohol
What do you
consumer.
find in the abdomen? You all seen. If you inspect carefully, lamba सांस लेते रहिए, and get down to the level of the patient, you will find some bulge here. Here. Yeah, right? It's moving on respiration, this bulge. Keep looking at it. Right? लंबा सांस लीजिए. See? Liver is very large, or this is gallbladder. There is a nodule here. It's a large liver actually. लंबा सांस. So it is hepatomegaly. And there is a globular swelling here, agreed. But yeah. Because here there is no enlargement here. But here you can feel that it is right up to this point, right? Did you palpate it?
Yes.
Whole thing is what nodule. This is the nodule he is referring to. And I don't feel anything separate from it. Yes, here I think maybe. It's a big
Yes.
mass.
Uh,
And this is nodular liver to me. And why it is not only liver is because there is no liver enlargement on this side. So this is the entire thing is a mass, and this is one, and this is the remaining liver, which is palpable. Here it's nodular, which is separate, and there is nothing here. So I would go by what you are saying. Lamba सांस, yes. Can you feel it? And there is a nodule which slips over it, something over that. Here, there you are. Now why is it not liver?
If we can insulate the fingers.
See now, see, I can insulate.
Yes, sir.
Lamba सांस. So it is not possible to do that in a liver. In a gallbladder also it can be done only where the gallbladder is not there. When there is gallbladder you can't do that also. See now I can insulate my finger. Lamba सांस. There I go. I can actually get about the swelling. So this is not. Bring your hand.
yes.
Bring your hand here. लंबा सांस. तो ना ही gallbladder है ना ही liver है. It is lying in right hypochondrium.
Number also.
This is the mass. And I can get about the swelling. Because I can get under the, see the costal margin. So now you said gallbladder. Lamba सांस. See now, here the space.
Yes.
And it's coming in. Who would want it? एक मिनट बच्चों, एक मिनट. लंबा सांस. Wait. छोड़ दीजिए. It comes back.
Yes, sir.
There's a gap in between, right?
Yes, sir.
I would be thinking in terms of
Colonic.
a colonic mass. See now, there is no, I can actually, why it is not hepatomegaly, the liver would have been enlarged here also, it can be in patches. Why is it not gallbladder, I can get above it. And patient has nothing specific to हेपेटोबिलिटी सिस्टम. पखाना कैसा होता है माता जी? सही होता है? कभी काले रंग का पखाना तो नहीं हुआ? भूख ठीक लगती है? So for me, this is a mass which is extending. It is definitely lying in this region, but it's mostly in the lumbar region. ऑपरेशन हो चुका? बच्चेदानी का ऑपरेशन. I would go by, all of you should try to get above it. Once you get above the swelling, you rule out लंबा सांस. See, I am actually, रोकिए जरा माता जी वहाँ लेके. हाँ, I'll show you something else. यहाँ आके खड़े होना माता जी.
एक बार खड़ी हो जाइए.
यहाँ आ जाइए. उधर देखो माता जी. लंबा सांस खींचो. हाँ. Now feel it. ये subcostal margin है. Where is the marker? This is subcostal margin. Where is the swelling?
Gone downwards.
लंबा सांस. I can get up. Yes. We are therefore. This is costal margin, no?
Yes, sir.
लंबा सांस माता जी. Nothing है. This लंबा सांस लेते रहो, घबरा क्यों रही हो? लेते रहो आराम से. Keep looking. लंबा सांस लेते रहो, लंबा खींचो, छोड़ो. लंबा खींचो, छोड़ो. So I have given you time for your eyes to adapt. It is not liver, not gallbladder. Chronic mass, why? One, it can be silent. Colon is large, and the mnemonic for the right-sided colonic malignancy, this may not be right side. We usually use the same mnemonic that we do for stomach, no? Lower
Yes, sir.
lump obstruction, anemia, asthenia, anorexia,
Yes, and
dyspepsia, and can be silent. So take a good history. The history of melena would support it further. Bowel symptoms are there. But relating to gallbladder, there are no symptoms. Pain is there, no radiation. It's not a classical biliary colic. So none of those features is there. Any investigation?
No, sir.
An ultrasound first
Ultrasound.
as an extension of clinical exam. Based on ultrasound will tell us which organ is involved. The organ of origin, followed by CT to look for the stage, the T and NM. It's not a gallbladder disease. Such a large gallbladder, such a long history, jaundice would have happened by now. And more importantly, when you examine, it should have features of a gallbladder mass. You can get above the swelling, you can get under the costal margin, so that itself excludes a liver or a gallbladder. And if it was liver, it will be occupying the whole of the liver. Doesn't grow in one part and leave the other part. So therefore, it's neither liver nor gallbladder. What else lies there? Colon. Which part of colon? Hepatic flexure, which will move on respiration as this is doing. But hepatic flexure growth, again you may not be able to get above the margin. So it's towards the transverse colon. So that's why it is a little relatively mobile, moving on respiration, and you are able to get above it. Okay?
Thank you, sir.
So hard consistency is hard. Surface is nodular. Lying in the region where the colon would be, you could get above the swelling, but it's moving on respiration. So we have the differential clearly sorted out. Liver is out, gallbladder is out, so what remains is colon.
So, but if this is a big mass in the colon, then how come the patient is not complaining of any bowel?
That's what I'm saying. So the large bowel masses can sometimes remain asymptomatic for a long time. So if you take her history more carefully, we will be able to find out about melena and some alternating constipation and diarrhea. That's where we need to spend time. She gives history of fever also. Sometimes the cecum gets pulled up.
Yes, sir.
And it's tuberculosis lying there. That also is a possibility. So we'll need to exclude that by investigation. But based on history and examination, you have to first exclude the gallbladder and liver. No? And then examination you exclude it. So naturally what is remaining is what you need to look for.
Thank you, sir.
she presented to us with complaint of pain abdomen and lump in the abdomen, the right upper quadrant region. And during the examination, we could feel there was a distinct mass in the right hypochondrial region and in the right lumbar region, which was separated from the liver, and slightly moving with the respiration with the nodular surface, and a nodule which we could feel on the liver.
Malignancy with liver metastasis. Colonic malignancy. So how should we proceed?
So we should first look for the number of metastases if we are planning for. We should look for the number of metastases in the liver. If it is an oligometastasis, maybe the patient is amenable for metastatectomy. Otherwise, routinely, so we can send for preoperative neoadjuvant chemotherapy to shrink down the size of.
First,
liver.
you would like to confirm.
The diagnosis. Right.
So what would you do for that?
So for confirmation, I would like to do a tissue biopsy by under colonoscopy guidance.
आराम से सांस लीजिए माता जी. See, I don't ask the patient to flex the knee or hip because I don't think that helps. It only restricts your area of working. लंबा सांस लेंगे माता जी. हाँ. So liver is enlarged. लंबा सांस लेते रहिए, छोड़ते जाइए बस. I can feel that there is a, but this is not liver. Because I can get above this. I think we have presented this before.
Yes,
This is here, and it's moving on respiration, but I can get above this. So it's attached to the colon. This is what I'm thinking. See, I can get above this, and I can get under the costal margin. Lamba सांस. So liver is just about palpable separately. The other method to find out is, see now, I'll ask her to take a deep breath and hold it. Lamba सांस लेके रोक लीजिए. She has held it now. I can actually find the upper border.
Yes.
And that's the lower border, which is
Yes,
gone
sir.
here. So it's moving on respiration. So this much is the movement.
Yes, sir.
This is normal. This is after expiration. So it's moving well on respiration. Okay? And because it is moving on respiration, naturally it's a intraperitoneal lump. And it is lying in the right hypochondrium, so the possibilities are there could be colon, which is what it is, because I already know it. I've discussed it with you guys earlier. And it's moving because it is attached to the part of the liver which is also enlarged, so hepatic flexure. But the liver is otherwise not palpable. This is where the liver is, according to my examination. And on taking a deep breath, it disappears. So, doing the span and percussion, second intercostal space, mid-clavicle line. Now, second, third, fourth, fifth. That's where the, actually between fifth and sixth, somewhere here. This is dull, resonant, dull, resonant, dull, resonant. So this is where I'll count it. Second, third, fourth, fifth and sixth. And I'll continue. Somebody asked a question, why don't we go down vertically, which is given in the book. The reason is, this is all bone here now. It will be dull, unnecessary. So you have to go into the space. Dull, resonant. लंबा सांस, resonant. छोड़ दीजिए आराम से. Dull. Same place became resonant and dull at the same time. See, it is dull. लंबा सांस, resonant. So this is a colonic mass, and we are discussing after you've done the ultrasound and CT. This is therefore a colonic mass with irregular surface, hard inconsistency, moving on respiration. Side to side mobility is also present, classical. But there is liver here, which is separate. So don't have to mix up the two. Lamba सांस फिर से बस. Now you see, I am talking about this mass. And since it is extending into the lumbar region, so Junaid asked last time this question, I remembered, yes? Bimanually palpable or not, that's when the allotment thing happened. Right? I can push it down and feel the posterior limit. So it is bimanually palpable, I don't need to do, see? It is bimanually palpable, so don't have to do allotment. But here's any lump in the lumbar region, see? Put your hand here, can you come here, camera? Put your hand, put your hand here.
Yes, sir.
Now it is gone. Now you feel. So it is bimanually palpable. See, if there was a gap between the anteabdominal wall and this lump, and there was fat in between which is liquid at body temperature, then the allotment would be required. Otherwise, it is not required. So what do we do now? We've done a CT. We found out that there are metastasis in the liver. We do an ultrasound guided FNA to confirm, and we can have a synchronous resection, but they look multiple, so that's the problem. If they're confined to one segment, they're multiple. In ideal case, if they're confined to one segment, you can still go for surgery if the patient performance status is good. Otherwise, patient gets neoadjuvant chemotherapy. We look for response here, and then we go for second surgery. That's one option. But if this is causing obstruction, we need to do the extended right hemicolectomy, which would go beyond the left branch of the middle colic, right colic, ileocolic. So all these pedicles have to be ligated at the base, and we go beyond this 10 centimeter of the small bowel also. That's what we'll plan, and this can be managed by chemotherapy. That's also an option. Any other option? So this is the second case, huh?
Yes, sir.
Any other option? You put the patient on neoadjuvant, response can be assessed, and then you can plan surgery subsequently.
So in between, she can go into obstruction also.
That's a good question. She is likely to. It's a large lump now. So in that case, we can go in for surgery as an emergency. So personally, if she is fit, anesthesia-wise, I am telling you how I would approach it. I would go for surgery of the primary, put her on adjuvant chemo, and take care of the
Metastasis.
because operate when she is fit.
Yes, sir.
I still feel the best palliation for colorectal surgery.
Colorectal cancer.
Cancer surgery. So if we have to do it some way or the other, this is what I'll do. But yes, we'll discuss the case in the MDT. And more often than not, they all agree on neoadjuvant first and then surgery. But that point in mind, if she comes in the middle of the night with obstruction, that's the wrong time to be operating on her for a definitive work. Like the other day,
Yes, sir.
you were operating on that patient with ascending mass problem or ileocecal growth or whatever, carcinoma cecum. So then you end up doing limited resection, which is not a good idea. Patient should get a radical surgery. So therefore my plan would be if she is PSC fit, we'll go for surgery. Liver mets we can handle by adjuvant Folfox or Folfiri. It's a metastatic disease, but as you rightly said, we'll look whether it's M1A or B, right?
Yes, sir. M1A is single orbit metastasis, M1B is multiple, and M1C is
So since it is only confined to liver, so it is still M1A. M1A is amenable to surgery. So we can go for it. How much is the CEA?
CA not done.
You were thinking of renal cell carcinoma at that time just because it was bimanually palpable. But you can find out that it's so freely mobile, unlike kidney, and secondly,
So it could be even involving the part of ascending colon which is retroperitoneal partially. So that's why maybe the growth.
No, any large lumbar mass would be bimanually palpable. But I think I've explained it before also. You don't call it ballotable and bimanually palpable at the same time. That makes no sense at all.
Right.
But you should be logical in your thinking. Otherwise, anything can be anything. You may still be wrong. The sensitivity of clinical examination is not so high in the best of hands. You do an ultrasound. So what did it come out to be? Colonic cancer only. So you were right in thinking it to be colonic.
Yes, sir.
So that confirms it, and we'll go ahead with our protocol.
Right. Thank you, sir.
The decision is taken. It was the CA colon. It has come out to be CA colon with multiple liver mets. We're getting the ultrasound guided FNA if possible. Otherwise, we're going for a section of the primary. This will be treated by chemo. Finished? No confusion about it. We'll do a radical colectomy. What is a complete mesocolic excision?
So the mesocolic excision in which we tie at the root vessel and along with all the lymphatic
take
are
the complete mesocolon along with the specimen without breaching the peripheral.
Like TME, no? TME is total mesorectal excision. There is a complete mesocolic excision for colon. Now this has been, it's a retrocolic part, like in pancreas, it's a dorsal part which is responsible for a poorer outcome. That's why people are going for that extra clearance after they've removed the uncinate to make sure that the local recurrence is prevented. And complete mesocolic excision is to get again the three-dimensional clearance. And there is something called as a mesocolon also. Like you have mesorectum, you have mesocolon. That is what it is. And naturally that is to clear off all the... Yes, and what is the Turnbull technique? It's not relevant here, but Turnbull, what is it?
Ligation of pedicle first.
no touch technique.
The answer is no touch technique.
That is called manual.
This is no touch technique, Turnbull. Very old concept, where it was believed that if you handle the colon first, like you did the other day mobilizing the primary, it leads to spread. It's been proven to be not correct. But in lap colectomy, it is required for technical reason, because if you don't like it, the vessels first, the specimen tends to, if you mobilize it, tends to fall on the camera. So technically it can be an issue. That's why they insist on doing the pedicle first approach, and that is something called as a no touch technique. So this is a decision for both the cases, and we can move